16. A pain in the middle. It was almost by accident that I became interested in the relationship between sugar and severe indigestion, or dyspepsia. I had been involved in the study of obesity and its treatment for a long time. For a number of theoretical reasons, I began several years ago to treat people with diets restricted in carbohydrate. At first, these diets were restricted mostly in carbohydrate, but also somewhat restricted in fat. After 2 or 3 years, however, I realized that it was necessary deliberately to restrict only carbohydrate, because it turned out in practice that if you do this, you automatically restrict your fat. For several years I have recommended this diet to all the very many overweight people I have seen, in the hospital or in my university department. As I point out in Chapter 2, such a diet more closely resembles what our ancestors ate during at least 2 million years of evolution. The theory behind it is more fully explained in the Penguin Encyclopedia of Nutrition. The diet allows you to eat as much as you like of meat, fish, eggs, leafy vegetables, butter, margarine, cream, or any oil or fat. It recommends that you take up to half a pound of fruit a day and 1 pint of milk. You are given a list of the carbohydrate content of foods and drinks in units of 5 grams, which I call carbohydrate units, and you are told to take about 10 of these in a day. My interviews with overweight patients begin with general questions about health, and some of these are about indigestion. Do you have indigestion or any sort of pain or discomfort after meals? Where do you have the pain? What sort of pain is it? How often do you have it? How long does it last? What do you take to relieve it? After lots of other questions about their health, the patients are examined and weighed and measured. After a few weeks of repeated visits by the patient, I go back to these questions and I find, for example, that having lost some weight, they are not so short of breath, not so tired, have no pains in their hip joints, no longer suffer from swollen ankles at the end of the day. All of these changes I expect, but as I first noticed years ago, many of them also said with surprise that my questions reminded them that they had stopped having indigestion. And this relief was observed not just after they had lost weight, but almost from the moment they had begun the low-carbohydrate diet. Let me interpose my personal experience. When I was young, I suffered from severe dyspepsia and was diagnosed as having a duodenal ulcer. I was given what was then very up-to-date advice, not to have an operation unless it became imperative, to continue my work, to take it easy, and not get too exhausted, and to avoid spicy foods, eat more frequently, and eat small meals. I gradually gave up cakes and pastries too, because I found I always got heartburn after these foods. But I still had quite frequently to take antacid preparations, such as magnesia or aluminium trisilicate. I later discovered that, like many very sedentary, middle-aged men, I was beginning to put on weight. Obviously, I now reduced my carbohydrate intake very considerably, as I had advised my patients to do, and this got my weight under control. Suddenly, a few months later, I became aware that my indigestion had almost entirely disappeared. On the strength of these observations, I decided to set up a proper test of the idea that a low-carbohydrate diet really does relieve the symptoms of indigestion. This was a more formidable undertaking than you might think. Severe indigestion often occurs in people who are under a great deal of stress, and so are not always very reliable in their statements. Secondly, indigestion often comes in bouts. A few weeks of pain, and then, for no apparent reason, a few weeks or even months with no pain at all. If you happen to be taking some treatment, any sort of treatment, before you have one of these intermissions, then you are likely to believe that it was the treatment that made you better. Thirdly, no doctor has a certain and objective measure of how much pain other people are experiencing. You have to accept their own estimate of whether this indigestion is better or worse, and if so, whether it is slightly or considerably better or worse. Nevertheless, I thought it was worth attempting to see whether a low-carbohydrate diet did improve the symptoms of dyspepsia. So we set up a fairly comprehensive scheme of experiments that would eliminate the difficulties, or at least minimize them. The tests were carried out at King's College Hospital in London. Physicians and surgeons were asked to send us anyone coming to them complaining of severe dyspepsia that had lasted, though perhaps not continuously, for more than 6 months. Many had had symptoms for 5 years or more. The only patients not included in our experiment were those who were going to have an operation for their condition. Each patient was carefully questioned and examined by a physician, and then sent on to a nutritionist. Alternate patients were instructed either in the conventional dietary treatment commonly used then, or in the low-carbohydrate diet. The conventional treatment consists of telling the patient to avoid fried foods and irritants, such as pickles or foods containing spices, to take frequent small meals, and to avoid alcohol, especially on an empty stomach. At intervals, each patient came back to the physician for assessment of the progress of his condition, and to the nutritionist to check the diet that he was following. The physician did not know which diet each patient was on. The nutritionist did not know how the patients were progressing. After 3 months, the diets of the patients were reversed, so that those taking the conventional diet were transferred to the low-carbohydrate diet, and those taking the low-carbohydrate diet transferred to the conventional diet. The experiment then continued for a further 3 months. Having made the conditions of the experiment so stringent, we were not surprised that it took us more than 2 years to get together information on 41 patients who had reported regularly for 6 months and had, as best we could judge, adhered to our instructions. From the detailed records kept by the physician, he and I then separately assessed their total progress and classified them as having shown no change or having reported various degrees of improvement or deterioration at the end of each 3-month period. Our assessment differed in only 1 or 2 instances as to the degree of change, but not once did we disagree as to whether the patient reported that he was better or worse or just the same. It was only after the clinical assessment that we looked to see whether the patient had begun with the low-carbohydrate diet or with the alternative diet. In summary, the results are pretty clear. Of the 41 patients in our trial, 2 said that they were worse on the low-carbohydrate diet. 11 said they were no different on either diet, but a decided majority, 28, said that they were very much better on the low-carbohydrate diet. Some of these were quite certain that the improvement was so great that nothing on earth was going to make them give up the low-carbohydrate diet. One said, "I feel better than I have been for 5 years." Another was even more enthusiastic. "I have never felt better round my stomach in all my life." The patients included men and women, some with gastric or duodenal ulcers, some with hiatus hernia, and some who probably had ulcers, which, as so often happens, had not been revealed by X-ray examination. These results, of course, pleased us a great deal. They suggested that chronic and severe indigestion from several causes could be greatly relieved by diet alone in something like 70% of patients. This result was especially pleasing because there had been increasing disappointment in the last few years about the results of dietary treatment of these conditions. Several research workers had put patients on fairly strict gastric diets: steamed fish, white meat, mashed potatoes, milk puddings, or on the more liberal but still fairly conventional diet I described earlier. All these investigators had concluded that the diets did not seem to relieve the severe dyspepsia of their patients, whether or not they had a definite ulcer. Now it can no longer be said that diet does not relieve severe dyspepsia. The right diet may well do so, but of course the wrong diet will not. The low-carbohydrate diet we had used in our study was limited in both starch and sugar. For a variety of reasons, we suspected that it was the reduction in sugar that was chiefly responsible for the improvement we saw, so we carried out a further experiment to look at the effect of sugar on a normal diet. Working with young men, we managed to persuade 7 of them to swallow a gastric tube first thing in the morning. They did this before and again after 2 weeks of a high-sugar diet. Through this tube we obtained samples of their gastric juices at rest, and then further samples were taken at 15-minute intervals after they had swallowed a bland test meal consisting mainly of pectin. Each sample was analyzed in the standard ways, most importantly by measuring the degree of acidity and digestive activity. The results showed that 2 weeks of a sugar-rich diet causes an increase in both acidity and digestive activity of the gastric juice, the sort of change you often find in people with such conditions as gastric or duodenal ulcer. The sugar-rich diet increased the acidity by 20% or so. The enzyme activity was increased nearly 3-fold. And let us remember that these effects were seen early in the morning, before breakfast. 2 weeks on the high-sugar diet had made the gastric mucous membrane much more sensitive to the very mild stimulus of the pectin test meal. Peptic ulcer. Our experiments on indigestion were carried out in the days before the new drugs cimetidine and ranitidine became available for the treatment of gastric and duodenal ulcers. 9 of the dyspeptic patients we had treated, of whom 6 had improved on our diet, had been diagnosed as having one or other of these peptic ulcers. Today these drugs are used to give good and prompt relief to most such patients, and their ulcers usually heal. Although the symptoms are likely to recur, they will probably be relieved again by the resumption of drug treatment. Strict diets are therefore now used far less frequently than they were for the treatment of either sort of ulcer. Nevertheless, there are always disadvantages in long-term drug treatment. Although cimetidine, and especially ranitidine, are unlikely to produce side effects, they do sometimes do so. Moreover, there are now more and more doctors, and especially patients, who are reluctant to embark on a course of drug treatment that may continue indefinitely, even though with intermissions. It is my own opinion that patients should be encouraged to try a low-carbohydrate diet before the decision is taken to use drug therapy. Patients with duodenal ulcer have been shown to have a diminished glucose tolerance and an increased blood insulin, 2 of the features produced by a diet high in sugar. Hiatus hernia. The type of dyspepsia that responds perhaps most strikingly to the low-carbohydrate diet is hiatus hernia. To understand this condition, you have to picture the esophagus, gullet, passing through the diaphragm as it leaves the chest and enters the abdomen to join the stomach. If there is a weakness in the diaphragm near where the esophagus passes, then pressure in the abdomen, from whatever cause, may push part of the abdominal esophagus and the adjoining portion of the stomach back through the weak part of the diaphragm. The usual symptoms are heartburn occurring soon after a meal, a feeling of excessive fullness of the stomach, and often a severe pain. Since food cannot easily pass into and through the stomach, some of its contents may pass back into the esophagus. The acid from the stomach can now irritate the esophagus and result in what is called reflux esophagitis. The pain occurs mostly at night and is considerably relieved if the patient sits up. The usual treatment includes advising the patient to eat small, non-irritant meals consisting of bland foods, like the so-called gastric diet. The last meal should be taken early rather than just before going to bed. The patient should avoid bending, lifting, or straining, and should reduce excessive body weight. Sleeping with a raised pillow can also help to ward off the pain. Most of this advice is worth following. However, our experience indicates that an even better diet is one in which the carbohydrate is considerably restricted and sugar virtually eliminated. Most patients have reported that having adopted this diet, they found significant relief for the first time. Gallstones. One of the conditions that often shows itself simply as indigestion is gallstones. The stones, which almost always contain a high concentration of cholesterol, frequently collect in the gallbladder, where they produce inflammation or cholecystitis. Gallstones are said to be present in 20% or so of adults, and rather more frequently in women than in men. But about half of these people never have symptoms. However, according to one up-to-date book of medicine, in prosperous countries the incidence of symptomatic gallstones seems to be increasing and occurring at an earlier age. Those individuals who do have symptoms of gallstones and have consequently been investigated have often been found to have one or two additional features. These include type 2 diabetes, hiatus hernia, an increased blood concentration of triglyceride and insulin, and obesity. For example, patients with gallstones weigh on average 5.5 kilograms more than patients with no symptoms of the disease. All this makes us think that, once more, we are dealing with a disease in which dietary sugar may be involved. This suggestion was reinforced by the fact that one of the patients whose dyspepsia was considerably improved in our trial of the low-carbohydrate diet was a patient whose dyspepsia had been diagnosed by her doctor as being caused by gallstones. This left us with the thought that perhaps her gallstone disease as well as her indigestion had been caused by her usual diet with sugar. Since we completed that study, some New Zealand research workers have reported finding that patients with gallstones tended to be taking more sugar than did people of the same age, sex, and occupation who did not have gallstones. They also had a higher concentration of insulin in the blood. Their report refers to 124 men and 219 women with gallstones, whom they compared with 111 normal men and 211 normal women. The results showed that the people with gallstones, both men and women, took more sugar, chiefly in beverages and confectionery, than did the control subjects. The authors calculated that an increase in daily sugar consumption by 40 grams, equivalent to 2 spoons of sugar in each of 3 or 4 cups of tea or coffee, more than doubled the risk of the individual developing gallstone disease. Again, other research workers found that sugar in the diet could produce gallstones in hamsters and in dogs. The latest research in England has shown that vegetarians are less likely than meat eaters to have gallstones. This could be due to something in meat that promotes gallstones, or something in vegetables that prevents their formation. But it may well be due to the fact that vegetarians tend to take less refined sugar and less sugary foods and drinks. Crohn's disease. Crohn's disease is an unpleasant condition of the alimentary canal which chiefly affects men and women between the ages of 20 and 40. Its chief characteristics are bouts of pain with diarrhea. The pain may be so severe as to mimic appendicitis. It can affect any part of the digestive tract. No one knows the cause of Crohn's disease, and there is as yet no satisfactory treatment. Occasionally it is necessary to remove the part of the bowel that is particularly badly affected. In a study in Bristol, England, 30 patients with recently diagnosed Crohn's disease were asked about their usual diet before they developed the disease. These diets were then compared with the diets of 30 healthy people matched for age, sex, and social class. The patients were found to have been taking 122 grams of sugar a day on average, compared with 65 grams for the control subjects. Their dietary fiber intake was slightly lower at 17.3 grams, compared with 19.2 grams. In other respects, the diets were much the same for patients and control subjects. The Bristol doctors then advised their patients to take a diet that was rich in fiber and low in sugar. They compared those diets and the patients' responses to this treatment over an average of 52 months, with the diets and responses of a carefully matched series of patients who had attended the same clinic in previous years. The results showed that the current patients had been admitted to hospital for an average total of 111 days during the 52-month study, compared with an average of 533 days for the patients who had not been on the new diet. The sugar intake of the current patients had been reduced to 30 grams a day, as compared with 90 grams for the non-diet treated patients. These findings have been confirmed by a similar study in Italy of 109 patients with Crohn's disease. There it was calculated that a diet with a high sugar content increased by 2.5 times the risk of developing the disease. The Italian doctors also examined the diets of people who developed ulcerative colitis. This is a condition with some resemblance to Crohn's disease, except that it affects only the large intestine, the colon, and there are no strictures in the bowel, but ulcers. These may become so severe and so deep as to perforate the bowel. The main symptom is bouts of severe diarrhea, with blood and sometimes pus in the stools. In some patients, it is difficult to distinguish whether they have ulcerative colitis or Crohn's disease. The Italian study was concerned with 124 patients. From an examination of their diets, the investigators calculated that here too a high consumption of sugar increased the chances of developing ulcerative colitis to 2.5 times that of persons with a low sugar consumption.